problem for you. So you'll notice the pressure will come down, the tidal volume should stay the same. The only things that can change with surfactants in those situations is that because your lung compliance changes and your time constants changes, because you get a change in time constant, you have to make sure that you're completing inspiration, completing expiration. Because sometimes if you're on a very fast respiratory rate, say you're 80, and that was plenty, that was your inspiratory time and expiratory time was so quick, you were completing your cycles. But suddenly, if your lung becomes more compliant, then actually that doesn't happen. And what's useful is if you have a baby that you give surfactant and very acutely your lung compliance immediately goes down, or your tube partially obstructs, then you can see that pattern on the ventilator. It looks like a poor lung compliant lung, and you sometimes have to turn up the Pmax to enable the surfactant to distribute further down, and then you see the tidal volumes on their way back up again. When I see that they're on the way back up, I'll tell people, hands off, don't do anything. Things are coming back again, let it re-recruit gently rather than disconnecting the baby and then attacking the baby. I find rapid... Oh, sorry. I think the other thing...
During recruitment, when you do recruitment, do you use, again, the graphics to help you? I mean, there is a debate about the... that we are exaggerating the importance of neonatal graphics. I don't know if you are with or against this.
Yeah, so I used to have one of the screens on the monitor set up so it's always showing pressure volume curves all the time, and I used to get very excited about looking at those, and another curve would be my flow volume curves. I've basically turned those off now. I find lots of people don't interpret them, but the beaking can be useful, but not that often. It was great back before we were using volume-guided ventilation to make sure you weren't over-distending lungs. It's not that reliable measure. It's of some use, but the problem is the lower inflection point. You almost always see a lower inflection point, and I find it's a very false reassuring sign for trying to build use increasing peak to recruit the lungs. So I've kind of gone off that. I try to teach our nurses and junior doctors to look at the waveforms, pressure, volume, and sometimes, mainly flow. Get used to that. Use that as your criteria for intervening. And once you get used to it, actually, you tend not to have to go and use pressure volume curves. To get good at one thing is the most important thing. People misinterpret things. And I also don't say a really useful thing I find with using high frequency oscillation, exactly as Dr. Trujillo was very nicely saying, is that when you give surfactant, you really can lose the idea of, am I now over-distending my lungs? Am I under-distending my lungs? The baby desaturates on high frequency. What is going on? And if I really don't know what's going on, because you get limited amount of information on graphics with high frequency, is I flick the baby back onto conventional, just momentarily, on volume-guided, 5 mils per kilo, and I see what mean airway pressure I'm getting. So if I'm on a mean airway pressure of 16, am I too high? Am I too low? The baby saturation is dropping. I can't get an X-ray for a while. I could go up and down on my mean airway pressure, but sometimes I will just switch to conventional volume guided, and I suddenly find I'm giving pressure off 12/4 with a mean airway pressure of 8, and I suddenly realize, wow, I've got far too high mean airway pressure, and I know it can come down very, very quickly. Or I see a pattern of an obstructed airway, which tells me I think I need to be doing some suction because I couldn't see that on the high frequency oscillator. Those graphics were lost to me. So briefly switching for a few seconds to conventional ventilation volume guided gives me a lot of insight as to what's going on with the lungs, which I tend to go and lose when I'm on a high frequency. So it's a nice little, pop out for 30 seconds, get an idea of what mean airway pressures we were using, because you can sometimes lose perspective, and then you can switch back again if you choose.
Yeah. Thank you, Dr. Pors, for your time. Thank you. Dr. Soa, are you going to present Michele?
And now I will present our last speaker, Professor Michele Pedicone. She's a registered respiratory therapist specializing in neonatal and pediatric respiratory care. She has enjoyed a rich career in academia as a professor in Highline College, Seattle Central College, SUNY Upstate University, and currently she's at East Tennessee State University. Her research includes non-invasive ventilation in the NICU, and she supports the global respiratory therapy education all over the world. Thank you so much. And she will present to us NAVA in the NICU.
Thank you very much for this invitation. Thank you, Dr. Soha. Thank you, Dr. Rania. It's my pleasure to be here today. I met Dr. Rania many years ago, and I really cherish our friendship, which has led me to be here with you today.
You were my roommate in Texas.
Yes, we were roommates in Texas. Yes, it was very exciting. I'm very excited to be here today with you to share some information about NAVA, some neurally adjusted ventilatory assist. And I'm going to go ahead and share my screen. And hopefully this one will work. Let's see. And slideshow from the beginning. Okay, can you see my screen?
Yes, dear, yeah.
Thank you. I just wanted to double check. I know Dr. Lisa had some issues earlier when she gave a fantastic talk. Thank you, Lisa. So we're going to talk a little bit about NAVA today, so neurally adjusted ventilatory assist. And we'll go through it in many steps because NAVA can be delivered both invasively and non-invasively. One thing that I like to do when I give this talk is to be in person because I really like to have things to show you. And I did bring a couple toys. I'm going to try to show you on the screen here. I feel that might help to explain things a little bit better if you can actually hold some of these things in your hands, manipulate them, and therefore help the concepts maybe to be a little bit more clear. This is something I find with my students that they really enjoy. So my objectives today are to define NAVA as a synchronous mode of ventilation, to discuss the benefits of non-invasive NAVA. So the NIV NAVA is what I will really be concentrating on as we go along today. Discuss some indications, contraindications, and some potential complications that we could see from this mode of ventilation. And I have no disclosures or conflicts to report. So here's a picture of a baby on NAVA. So NAVA, in my experience, has been used in the NICU. So this is where I have used NAVA. However, we are seeing some success using NAVA in COPD patients. So you can keep that in the back of your mind. NAVA is a mode of ventilation that can be used for itty bitty babies, preemies, very low birth weight, and also elderly or those with COPD. So again, on the one side, the invasive NAVA is being used with this patient is obviously intubated with the endotracheal tube. And oops, sorry, I apologize for that. If you can see this right here, this is the NAVA catheter, which we'll talk about more later. The NAVA catheter goes straight to this cable. It'll hook into a cable right here that goes straight to the ventilator that will measure the diaphragmatic activity of the baby. And then on this side here, this baby is receiving NAVA through, it kind of looks like a CPAP generator mask. And we can also deliver NAVA through the Hudson prongs, and it's also been successfully delivered through the RAM cannula. So NAVA, neurally adjusted ventilatory assist, what does this mean? So NAVA is, it stands for neurally adjusted ventilatory assist. And the goal of NAVA, and specifically non-invasive NAVA that we're really concentrating on today, is to promote improved work of breathing by providing better synchrony between the patient and the ventilator. So in NAVA ventilation, the vent senses the beginning of the diaphragm excitation and delivers a breath to the patient's desire. And we will go over this in a little bit more detail. So how it works, it is proprietary. The ventilator will deliver breaths in synchrony with and in proportion to the electrical activity of the diaphragm. So what I mean by proprietary, it's NAVA is specific to a certain ventilator. And in this case, NAVA is specific to Mackay. Mackay makes the NAVA mode and the little module that goes into NAVA that actually works well to sense this excitation of the patient diaphragm. So the patient respiratory drive controls the rate and the depth of the ventilation. So basically the patient is setting their own rate, tidal volume, eye time. So think about this, how synchronous this is. A nasal or orogastric catheter with sensors is inserted into the esophagus to the level of the diaphragm and senses this excitation. And then a flow and a preset pressure are delivered, and then the breath ends when the sensors sense that the diaphragmatic relaxation has occurred. So in order to better understand NAVA, I think we need to look a little bit about neuroventilatory coupling. So the signal starts from the central nervous system, and goes down the phrenic nerve and excites the diaphragm. When the diaphragm contracts, the chest wall and the lung expand, causing airway and pressure to change in the lungs. When the flow changes in the lungs, it initiates a flow trigger that communicates with the ventilator that a breath is coming, and the ventilator then gives this assisted breath. When this happens with a flow trigger, there's an inherent trigger delay between the start of the breath and the assistance from the ventilator. So this is not always in synchrony. The neural trigger shown in the middle of the screen, so right here, if you can see my cursor, that is where NAVA kicks in. So this neural trigger here in the middle of the slide detects when the diaphragm becomes excited. And not only does it decrease the trigger delay between the breath and the ventilator, but the neural trigger actually controls the diaphragm, which controls the size of the breath that the baby will get. So the baby's in control. And this is just another way of looking at it. Again, the patient will send the signal from the brain via the phrenic nerve to contract the diaphragm. The diaphragm receives the signal and begins to contract, and we call that the EDI max or the EDI peak. So EDI just being for the electrical activity of the diaphragm. Then the flow will begin from the ventilator based on the contraction of the diaphragm. And when the lungs are full, the brain sends the signal to the diaphragm to relax. And when the diaphragm relaxes, the flow from the ventilator stops. And then the patient exhales to what in NAVA terminology is called the EDI min. So basically the minimum amount of work that the diaphragm has to do. So at rest, diaphragm at rest. So to sense this, the NAVA works via a catheter. So a catheter is inserted into the esophagus, and it detects the electrical activity signals. And it uses that strength to help determine how much pressure, how much support to deliver to the baby. And it's based on each breath. It's not based on trending. So each breath, the baby decides what they want, and that is what they get. So the NAVA catheter, and I happen to have one here right now, I don't know if you can see it, but here is the NAVA catheter. And this NAVA catheter has electrodes embedded in the base of the catheter here. And I can feel them by running my fingernail over them. So the electrodes are down here in the base of the catheter. So this catheter has a port right here where you can hook up a feeding tube. You can feed the baby through this catheter. You can administer medications. And these electrodes in the catheter measure the diaphragmatic activity 62.5 times per second. So you know that is going to be very synchronous and is in real time. The other end of the catheter has this cable. Oops. This cable here, which will connect into, I think I have a photo here. There we go. Which will connect into the cable that goes to the module, which goes into the ventilator. So it's a very handy piece of equipment. It comes in 3 sizes. This is a 6 French for our babies that are less than 1 kilo. And you don't lubricate, you just use some sterile water. It's very, very soft and very pliable. And it goes, in a perfect world, you're going to get it on the first try. And we monitor the correct placement by looking at the screen of the ventilator, where we can make sure that it's in the proper placement. And again, that does take some training. Here is where you can see the catheter. in the esophagus. So number 2 is the esophagus, and 3 is to show the level of the diaphragm, and then 4 is the gastric mucosa. So you can see most of those electrodes are at the base are right there at the diaphragm. So they are sensing that electrical activity. So just again, briefly, some NAVA terminology. So EDI is the electrical activity of the diaphragm, and it can be thought of as a respiratory vital sign. The peak, EDI peak or max, is the highest value of the EDI signal during a single breath. The EDI min represents the spontaneous tonic activity of the diaphragm, which prevents derecruitment of alveoli during expiration. And then there is a NAVA level, and that is the gain factor that converts the EDI signal into the proportional pressure. So the higher the NAVA level, the more workup breathing the ventilator is providing to the patient. So just briefly, so Khalil and his group in 2016 took a group of I think it was over a couple years, saw 60 infants that were preemies, 28 to 36.6 weeks, and they required invasive mechanical ventilation due to respiratory distress, and they found that NAVA improved patient ventilator synchrony. It decreased peak inspiratory pressure, decreased oxygen requirement, decreased the need for sedation in this patient population. However, it did not decrease the duration of mechanical ventilation or length of stay in the hospital, and it was not found to be appropriate for patients with PPHN. So we are finding that although we enjoy using NAVA, in fact, at the University of Washington right now, there are 5 patients, I just checked yesterday, there's 5 patients on this modality using NAVA. However, they have found it's more appropriate for patients with respiratory distress and also for the BPD patients, but not necessarily for those patients who are suffering from the persistent pulmonary hypertension. So non-invasive is where most of my experience lies. And non-invasive, it operates the same way. You also have that same NAVA catheter is still embedded in the esophagus reading the electrical activity. And it delivers synchronized breath support, proportionally adjusted. And the infant chooses the rate, infant chooses the I time. And if the infant puts in more respiratory effort, if have it work a little bit harder, then the ventilator kicks in and provides more support. The ventilator cycles off to a set PEEP. When the EDI, so the electrical activity of the diaphragm, falls to 70% of its peak value. And those are important components that we do measure on the ventilator. We will measure our EDI peaks, our EDI mins, our NAVA levels, and we also will look at any time that the patient may go into apnea. As we know, with this patient population, it does happen quite frequently. But with this type of technology, we can monitor how often, when, and maybe do some correlation. Are these patients heading more into apnea during feeding times or particular medication or care times or patient parents handling and the like? So here is a screenshot of the face of the monitor, kind of try to explain a little bit better here. So the pressure, so the upper, pressure, flow, and volume, and then the bottom one right here is the EDI level. So note the synchrony and the proportionality between the EDI and the ventilator pressure. So every time the ventilator pressure is higher, so is the EDI. Look at how synchronous this is. And even when the patient is taking a small breath, the EDI is supporting at a lower amount. Conversely, if the patient is requiring more, the EDI is delivering more. So again, this shows the synchronicity of this particular mode of ventilation and how it responds and correlates very well with what the patients are doing. This particular screen, and I hope you can see it over there on the side, is showing a 92% leak. So NAVA is still delivering appropriately with such a large leak. Here's another picture showing essentially the same thing, but this leakage is much smaller. I just felt that this might give the graphics just seem better in the color on this particular screen, showing the same thing where it's all in proportion. Everything is in proportion. Whatever the baby needs, the EDI NAVA is going to deliver. Benefits. All right. So NIV-NAVA delivers synchronized ventilation independent of leaks and changes during each respiratory cycle. So again, the ventilator doesn't have to look at trends and determine what to deliver to the patient. The NAVA results in improved patient-ventilator interaction and effective ventilation at levels determined by the patient. And it has a great potential as a mode of respiratory support in neonates to prevent endotracheal intubation, which is where, in my experience, the non-invasive NAVA has really shown its strength. When we've had a patient who maybe is not doing so well on a cannula or a CPAP type of device, we can switch them onto NAVA and we can monitor them more closely. And oftentimes, because it's more synchronous, and it also will provide a backup just in case. You always have that safety built in. So when we have switched patients to the non-invasive NAVA from CPAP, they have been supported better and have been more successful. This can also help to, as when you're extubating a patient, when you're weaning, this can be a step down. You can go from invasive NAVA to non-invasive NAVA because you're using the same machine. The catheter is already indwelling into the patient, reading the signals, and you just switch them over. So here's a little picture of a patient on the Hudson prongs and the RAM cannula. These are the two things that I have seen most popularly used with NAVA, keeping in mind that with the RAM cannula at times there's more back pressure, so your headings, your readings might be a little bit different due to the diameter of the catheter. So who is my ideal NAVA patient? I'm glad you asked. This baby has to be breathing, have an intact diaphragm where at least one side with an intact phrenic nerve. Intact neurological drive, because remember, the baby has to be breathing. And ability to place either a nasogastric or an orogastric catheter. As with everything, there's always some contradictions and some complications that we should be aware of before we just run in and try to place every patient on NAVA. Again, that's not appropriate for 100% of our patients in the NICU. So some contraindications would be an absent electrical signal from the brain to the diaphragm. If the baby is undergoing some type of paralysis or neuromuscular blockade. If there's esophageal bleeding and the inability to place the catheter. Complications that we have seen is some abdominal distension, irritation from the catheter, and possibly even a pneumothorax. But I've never seen a pneumothorax with a non-invasive NAVA. Doesn't mean that they haven't seen them at other centers. There's a huge body of evidence, and briefly, NAVA protects tidal volumes, lowers inspiratory pressures, improves tidal volume variability, gives better gas exchange, and leads to improved synchrony. So the title of my talk was NAVA as a ventilator strategy, which I think we kind of talked about already, or a ventilation tragedy. And I think this is important to note as well, because oftentimes, especially if it's new, if you're rolling out a new type of technology, you might find a lot of your staff or people who are monitoring these devices, maybe they don't like change, or maybe they're a little hard to accept change or difficult to change their mind of thinking. And that is something that we have seen. NAVA requires monitoring. It requires, in the United States, we have respiratory therapists, and we handle the NAVA. We are the ones who manipulate it, adjust it, and set it up, and monitor it, manage it ongoing. So here's an example of the NAVA settings that we would be most caring of. So our primary settings are going to be our NAVA level, our PEEP, our FiO2, and our what triggers our electrical activity of the diaphragm. We're going to have some secondary settings, and we're always going to have backup ventilation. We're going to have emergency settings. And this is important because it can happen where this catheter especially if it's in the patient's mouth, gets all gummy and gooey. You know how they have those excess secretions, and it might become dislodged. And if that would happen, then those electrodes may not do the best job of being able to work appropriately as they're meant to do. So when the ventilator senses that something like this has happened, the ventilator will kick in and deliver some backup breaths and some pressure above PEEP, and it also has an apnea delay. So again, safety is important. If the catheter falls out, or if for some reason it's not working appropriately, the ventilator will default to the pressure support mode, and the NAVA will resume when it's working again. And if you don't see an EDI signal on your monitor screen, or if the baby goes apneic, then there is backup ventilation. Again, safety is always of utmost importance. A few studies out there. So Tabakaru and his group in 2017 with 108 very low birth weight babies over 2 years found that non-invasive NAVA decreased bradycardic episodes. So Wrong and his group in 2017 over 2 years, again with some preemies, found that NAVA decreased the total duration of respiratory support needed. And it was well tolerated, and it decreased the need for sedation. Again, remember that this works, a leak doesn't impact it working. It can still deliver and the support even if there's a leak. And if you've ever tried to really work on those CPAP generator masks and stuff like that, you know that leaks can be a problem. That's why this NAVA device has been so successful. So Parma and his group in 2017 with 33 infants of preemies found that NAVA decreased the median oxygen requirement and decreased carbon dioxide levels. So these babies are ventilating and oxygenating better. And then Firestone and just last year found that NAVA is a valuable tool to prevent intubation, facilitate extubation, and as a rescue therapy for those patients who may be failing CPAP. So I want to leave you with just a couple babies that I cherish and who have successfully been ventilated with this form of ventilation. So baby Elvira was a 25-week gestation infant with severe RDS. She was intubated and given surfactant and placed on pressure control. And then after a few days, she was switched to SIMV. At 12 days of age, she was placed on non-invasive NAVA. And then by the time she was about a month old, she was placed on a heated high flow nasal cannula, And on her 2-month birthday, we were able to put her in room air. And here she is being cared for one of my colleagues at the University of Washington. And baby Mindy was a 28-week gestation infant who was only 674 grams. That was her birth weight. So we proceeded to do insure with her. So intubate, surfactant, and then extubate, and put her directly to non-invasive NAVA. And after 17 days, she was placed on a nasal cannula. And there she is, looking all sweet and happy. There is a huge body of evidence for NAVA and NAVA success. And there's just some of the references that I was able to use in this talk. So there you go. And thank you very much. I don't know if there's any questions. I hope I didn't run over my time. Looks like I'm spot on.
Thanks a lot, dear Michele. You make it simple and sweet.
Yes. Well, that was the goal. Thank you so much. I can only, again, talk to my experiences. I know that the research in NAVA is just ongoing because, you know, although this type of technology has been around since the 80s, that we've only really started doing adult and baby trials in the early 2000s. So in that respect, I mean, it's been 20 years, but it still seems kind of young. And since it's not widely accepted all over the world yet, there's still a lot of centers who are not comfortable using it.
Thank you, dear. So we have reached to the questions and answers. I guess Lisa have answered her questions in the Q&A section. John, are you with us? Dear John? It seems not. So, any further question, Dr. Khaled, Dr. Hisham? Thank you. Daniel, do you have any comment?
Yeah, once again, thanks for inviting me to this forum. Great presentations. Like Michelle, I have quite a bit of experience with NAVA, just with a larger patient population, and that was a very good presentation. Having staff buy-in certainly is very important in order for its clinical utility to really be understood and utilized appropriately at the bedside. At the University of Virginia Medical Center, when we were using it in the early 2000s, after FDA approval, I had quite a bit of enthusiasm with NAVA, but there was less enthusiasm among my colleagues except for in neonatal pediatrics, where we still use it today.
Yeah, actually, we don't have yet NAVA here in our center, but hopefully I was thinking that Michelle's talk, which will be like throwing a stone into water.
Ripple effect, I love it.
Saad, do you have any other comment, Dr. Saad?
Thank you, Dr. Michele. It was a really a nice presentation, and we are really enthusiastic to use NAVA here in Egypt.
Excellent. I believe my research has shown that it is being used in your area, just not at your institution.
Yes, we didn't.
Dr. Khaled, do you have NAVA in Dubai?
To tell you the truth, we have it in other centers, but in our centers, we could not succeed in implementing NAVA. I'm not sure, maybe because of the old machine. They are telling that the new machines, the updated ones, are better ones. But whenever we tried it, we could not achieve the results that we wanted. The other centers in Abu Dhabi and Al Ain, they are using it and they are having successful results.
Hopefully one day you will reach. Thank you. Thank you, Danny, Dr. Khaled, John, Lisa, Dr. Soha, everybody. Thank you. And see you
Soha.
Maybe face-to-face here in Cairo soon.
Inshallah.
Bye. Thank you, Dr. Gore.
Thank you.
Thank you. See you soon. Bye.
Stay well.
ازيك يا سهى؟
Dr. Khaled is